Hello everyone, welcome to my YouTube channel where I make pharmacology simple to understand. Today I have a very interesting topic, unraveling carbamazepine. This is Professor Kennedy Edem Kukuya and I'm happy to have you here. And so what is carbamazepine? Now, this is the structure of carbamazepine. It is a drug that we consider to be quite critical in the treatment of various neurological and psychiatric conditions, such as epilepsy. We could use it in migraine. We could use it in bipolar disorder, in addressing the manic phase. We could use it in neuropathic pain. And so this drug is very important. But how exactly does it work? If you've watched our previous videos, you'd realize that we've talked about sodium channels, voltage-gated sodium channels, and how they play a role in epilepsy. If you have not watched that yet, I would advise that you go back and watch that. That will help you appreciate what we are explaining here. Now, so carbamazepine binds to the inactivated state of the voltage-gated sodium channels and reduce repeated firing of impulses in the brain. And so by reducing that repeated firing, the seizures that the person would experience is reduced. Again, if these repeated firing of impulses conduct pain impulses, then by blocking them, we are also able to address the pain. If the repeated firing of impulses are the reasons why the person is in the manic phase of the bipolar disorder, we address that and the person's mood is normalized. So let's look at some aspects of the pharmacokinetics of this drug. Briefly, we look at the absorption, which I label A. So normally the absorption of carbamazepine is slow and variable. Especially we have about 3 formulations. The oral formulations, we have about 3 of them. We could think of what we call the immediate release formulation. We have the controlled release. And then we have the sustained release. Now, when we pick the immediate release, the absorption is quite slow, it is erratic, it's not reliable, but the controlled release and the sustained release have better absorption profile, okay? One of the things we also want to note is that the presence of fatty food can increase the absorption of these drugs. Another thing that you want to look at is metabolism. How are these drugs metabolized? They are metabolized mainly in the liver. So carbamazepine is metabolized in the liver using cytochrome P453A4. And knowing that they are metabolized by cytochrome P453A4 tells us that this drug may be associated with a lot of drug-drug interactions. 2, we also want to note that carbamazepine is not associated with first-pass metabolism. So when it is going through the GIT, it goes through the liver, it is not broken down before it enters systemic circulation. So there is no first-pass metabolism. Another important information is about the fact that carbamazepine is an enzyme inducer. Now, because it is an enzyme inducer, it may speed up the metabolism of other drugs and reduce their effectiveness. So that is one thing. But even if the person is not taking any other drug aside the carbamazepine, the fact that it is an enzyme inducer and the enzyme it induces is the same one that metabolizes it, it happens that the drug causes its own or stimulates its own metabolism. So we call that auto-induction. And so a previously effective drug for your patient, after a number of days to weeks, that drug may not do the same work it is doing anymore. And so if you don't have that in your mind, you may think that the person has become resistant or refractory to the drug's effect, when in actual fact, it is because of the auto-induction. And so now the drug is being cleared from the system faster. Usually during the metabolism of the drug is converted to an epoxide because the metabolism involves oxidation. So we have carbamazepine 10-11 epoxide, which in itself has some anticonvulsant effect, right? And both the parent compound, which is carbamazepine, and then the metabolite that is produced are eliminated renally. So one other thing I want us to look at is the diurnal rhythm that is associated with carbamazepine. And so usually in the mornings, we have higher concentration of the carbamazepine in the serum as compared to evening. And so it means that if we relate the concentration of the drug to the effect of the drug, then the drug may work better in the morning than in the evening. Now, if you were to give divided doses, it would mean that you might probably need a higher dose in the evening in order to achieve the level of concentration you need as compared to morning. So that is important. Now, another thing that I would want us to look at is the adverse effects or the side effects that are associated with carbamazepine. There are quite a number of them. We would want to address them. So CNS effects, we have dizziness, we would have drowsiness, blurred vision, we would have nausea, headache, there could be diplopia, there could be ataxia or nystagmus. These are various CNS associated adverse effects. And I guess about 35 to 50% of your patients on carbamazepine would likely experience a combination of these. Then there is also the GIT-related adverse effects because of the irritation of the drug on the gastrointestinal mucosa, mainly nausea. Now you'll notice that there's nausea under CNS, nausea under GIT. How do we differentiate that? So when the person is on carbamazepine and the person is experiencing nausea, if taking food before taking the drug or taking the drug with meals reduces the nausea, then we can say, or we can infer that it's likely gastrointestinally mediated nausea. But if the person takes the food and still the drug keeps on producing the nausea, then normally we feel that it is a CNS-related nausea, which may be telling us that there is some neurotoxicity happening. And sometimes it is an alarm taken for us to decide on discontinuing therapy with the carbamazepine. Another thing is the fact that some people on carbamazepine may experience aplastic anemia and agranulocytosis, and this could potentially be fatal. You could also have situations where we may want to be checking neutrophil count because there could be neutropenia, and we may want to monitor that because when the levels fall below a particular count, we may need to stop administering the carbamazepine. Another thing is the metabolic conditions like hyponatremia. This may be more severe in the elderly or in people that are volume depleted or people that are on various diuretics that may cause hyponatremia. Now, there could also be some hypersensitivity reactions where people may have some skin rashes and all that, okay? So this about some of the side effects or adverse effects associated with carbamazepine. I would want to say that if we administer carbamazepine, to summarize, you may be administering it because you are trying to treat epilepsy. You may be administering it because you are trying to address migraine, neuropathic pain. You may be addressing some mood disorders like bipolar disorder. And in terms of epilepsy, we may use it mainly for partial seizures or generalized tonic-clonic seizures. It is important to state that carbamazepine does not work in absence seizures. Does not work in absence seizures. It usually would worsen the absence seizures. So be careful with that. Now the last one that I would want to add, issues with pregnancy. Issues with pregnancy. And so although it is not contraindicated in pregnancy, we must know that carbamazepine has the tendency of causing teratogenic effect in the babies, some congenital abnormalities. And so people of childbearing age, women of childbearing age, may be warned against maybe getting pregnant while they are on carbamazepine because of this teratogenicity. But it doesn't mean that we cannot give it while the woman is pregnant. We'd have to weigh the risk against the benefits. This about all time would permit us. Thank you for making time to watch. As usual, I would ask that you subscribe to my channel, and I hope to come your way again with more topics in pharmacology. Once again, this is Professor Kennedy Edem Bukia.